Charles Clinton with the Heart of Medicine, and we're gonna power through the questions I did yesterday, 4th of July, 2025, and it was a Friday, so, well, I was off, so I was able to get about a block of 55 questions, getting ready for the ABIM examination, Internal Medicine Certification examination. So now I'm here in Miami, completing or starting cardiology fellowship, and we'll just go through these questions, what I learned, the clinical pearls from each, and leave me any feedback, anything you learned, anything I said incorrectly. Also, you feel free to correct me. The idea for these videos is for anyone that is walking the dog, is washing dishes, this and that, you're busy. So that's the idea. So I'm not going to waste any more of your time. Let's power through them. Question number one. The main thing in this question is, how do you avoid or prevent ventilator-associated pneumonia? So you probably don't even have to read the whole entire thing for that, because there's some questions that you actually don't have to read through the entire paragraph. That's why I recommend you just going immediately to the question and what it's asking you, and sometimes you can sort it out. So I actually did that initially. So I thought to myself, just how can I inhibit ventilator-associated pneumonia? And I saw the options. What happened is that my brain played a trick on me, and I'm like, okay, patient that is intubated usually will require, that's usually a patient that is critically ill, intubated, is going to need a anti-acidic or anti-stomach acid, right? Such as a PPI or an anti-H2 receptor blocker. So, for example, omeprazole, pantoprazole as PPIs, or famotidine as a histamine 2 receptor blocker. But I just thought about that, and I'm like, okay, this is an easy answer. Boom, I marked it and moved on. But I forgot about what the question was asking me. The question was asking me, how can I avoid ventilator-associated pneumonia? They weren't asking me, how can I reduce the risk of bleeding, stress ulcers in that patient? So the way you remember that PPIs are actually associated with, some say non-significant, some, there's been debate on this topic for a while, but it is said that PPIs can potentially increase a little bit your risk for ventilator-associated pneumonia, because it can increase, what is it, like regurgitation, and by altering the pH in the stomach can potentially make other microorganisms grow and not to be killed, and increase your risk for pneumonia. But that, of course, was not the question. They're asking me, how do you avoid ventilator-associated pneumonia? And the answer was oral care with antiseptic solution. Every patient that is intubated requires oral care. If you have patient with teeth rotting after being intubated for weeks or so, that's a marker that the system you're working in probably is in deep trouble, because that shouldn't happen. Every patient should have adequate oral care. And I'm going to tell you an interesting story. One place I worked in the past, in a different continent, where I come from, Costa Rica, there was a patient that was intubated for many, many weeks. And one day the nurse calls us in, and we go in and we see the patient, and they're like, come and see what's coming out of this patient's mouth. You won't believe it. And there was literally larva from, I don't know which type of flies, but larva in the mouth. So that was definitely horrible. And we thought to ourselves that was horribly bad. And we're not sure exactly why that happened. It wasn't my patient, but I remember that we were like, oh man, this is very, very bad, right? So, well, I just remember that, of course, you'd never want any patient of yours that is intubated to have any risk of any of these things happening. Not that I'm thinking that this patient had a fly like go in there while intubated and lay an egg and that became a larva. Not that I'm thinking that necessarily, but that could potentially have happened. So, yes, every intubated patient, adequate oral care with antiseptic solution. Other things to do, hand hygiene, of course, non-invasive ventilation when possible, daily sedation and weaning protocols, orogastric tubes, and those are the general things. How to prevent aspiration: you can do semi-Fowler's, which is 30 to 45 degree angle, aspiration of subglottic secretions, endotracheal tube cuff pressure more than 20 centimeter water, because that's how you will tamponade out that backflow of fluid from going into the airway. And you reduce colonization based on the things we just spoke about. Okay, so here you see that if you can avoid proton pump inhibitors and histamine receptor blocking agents, do it. So if this is a patient that has been just intubated, maybe you're intubating this patient for less than 48 hours, probably you won't need proton pump inhibitor or histamine receptor blocking agents. Or if this patient is improving and has been tolerating well the enteral route and the clinical condition is improving, and you think that you're going to be able to extubate them soon, probably you can start maybe weaning off or stopping these medications just to reduce that potential additional risk. And that's it for this question. Let's go on to the next one. This other question is, patient asks about potential complications of mitral valve prolapse. Which of the following is the most important determinant of adverse cardiovascular events in this patient? So this is one of those that you can try to answer just going to the question options. So anxiety disorder, no, there's things that are going to be stronger. So you'll see degree of microregurgitation. That's always going to be very important in any valvular disease. It's very different for you having mild aortic stenosis from severe aortic stenosis. Same thing for microregurgitation. Okay, same thing for any valve disorder. So that's definitely going to be a strong contender. And what else did I leave here? I was like, okay, maybe non-exertional chest pain. Let me go, and then I read this real quick to see if there was anything special. But remember that this patient with the anxiety, that if this patient is heightenedly anxious and also has non-exertional chest pain, that could potentially be anxiety. So it's just like telling you, no, it might be a confounder. So that probably was not it. So in summary, yes, the degree of microregurgitation is very important in outcomes. And basically that's what we were talking about. So moderate to severe microregurgitation and a reduced ejection fraction less than 50% are associated with an increased risk of adverse cardiovascular events, including arrhythmia, embolic stroke, infective endocarditis, decompensated heart failure, and sudden cardiac death. Now this other question, Okay, this is a 65-year-old man who says he was getting up a couple times a night to go pee. He was also having straining, so he was having signs and symptoms of benign prostatic hyperplasia. And this is confirmed with the physical exam showing the prostate being mildly enlarged, symmetric, and non-tender. So, which is the most appropriate next step in management of this patient? So, this patient is coming in like a new de novo patient where you're just diagnosing benign prostatic hyperplasia. So, what's your next step? So, I thought that maybe advising behavior modification and observation wouldn't be the best answer because they weren't telling me the patient was drinking a lot of fluid before going to sleep. They weren't telling me that. So since they weren't giving me specific signs and clues, I'm like, maybe we can just go to medications. But the usual medication I would go first with would be a alpha 2 blocker. So it would be tamsulosin, doxazosin, alprazosin. But yeah, finasteride is a what is it? It's a testosterone blocker, right? Testosterone receptor blocker. Um, yeah, so that's an option, but I think it's not the first line option. I think you first go with the alpha 2 blockers. Let's see why this was incorrect, okay? So the first thing you want to do with once you diagnose benign prostatic hyperplasia is going to be let's see if they had measure post-void residual volume. I also wanted to measure that, but it wasn't the answer. So let's see what else we have. Treatment. Mild symptoms, do behavioral modification. So that's what we had to do. And after mild symptoms, if the symptoms are moderate to severe, then you do alpha blockers or you do 5-alpha reductase inhibitors. That would be finasteride. Or if severe enough and not responding well to the medications, you would do an invasive procedure such as TURP, which is the transurethral resection of the prostate. So that's the answer, basically. Why wasn't it measuring post-void residual volume? Because I guess we already had enough clues to diagnose prostatic hyperplasia, and we probably didn't have to do that. Let's see why option number C was not the answer. It would be useful in patients with urge incontinence who are being considered for treatment with an anticholinergic agent, or in those with BPH and symptoms of overflow incontinence, such as involuntary leakage of urine. However, it is not indicated in patients with mild BPH symptoms. Okay. Why wasn't it the 5-alpha reductase inhibitors? So let's see. When medication is indicated, alpha 1 adrenergic antagonist. So I have said that incorrect a couple of times. It's alpha 1 adrenergic antagonist. So it's not alpha 2, it's alpha 1. Those are the family of tamsulosin, doxazosin, prazosin. Those are those medications, and terazosin. Those are the first line treatment. And then, if that's not the best, then you can, if that's not cutting it, you can do 5-alpha reductase inhibitors such as finasteride, which is generally less effective and slower to act, and are more effective in men with a large prostate volume rather than in those with mild enlargement, as in this patient. So that's the reason that was the answer for this question. Now we'll go to the next question. So this other question was a little bit tricky, but we were able to get it. So they were basically asking us, a patient, all this is telling us is this patient had hepatitis C that was untreated, it became cirrhosis, and the cirrhosis, well, this cirrhotic patient is now having this saturation easily, or 88% saturation on room air, with peripheral edema, with new spider nevi. So all the manifestations of advanced cirrhosis and also the desaturation. So this would make you think of hepatopulmonary syndrome, which in general isn't that frequent. I think it's becoming a little more frequent maybe nowadays because we're suspecting it more. But in summary, cirrhotic patients with you have no clear-cut cause for the desaturation, you can consider this potentially being hepatopulmonary syndrome. And the way you diagnose this is with IV, or not IV, with contrasted echo, or other words, bubble study. So the agitated saline will work as contrast because when you agitate the saline, it increases the capacity of you to see this fluid in the heart chambers. So it sort of works like a cheap way of contrast without it having to be necessarily contrast. So there's a clinical, let's see, a triad of liver disease, decreased oxygenation, and IPVDs. So that's intrapulmonary vascular dilations. So with the agitated saline echo, what you will see is like bubbles crossing from the right to the left atria. So this has its own little like science. It depends on how much time. So when you have late appearance of microbubbles in the left heart, or meaning after 3 heartbeats, it's usually late, and it's telling you that there's an intrapulmonary shunt, and this is associated to hepatopulmonary syndrome. But when you have bubbles in the first 3 beats passing from the left to the right heart, it usually is more likely, such as an interatrial communication. So that's why when it's late, it's telling you it's a little farther, this communication in the lung, and that's how you can diagnose the hepatopulmonary syndrome in summary. So that's why that was the answer. Now let's go on to the next one. This other patient, that's a patient with Parkinson's disease that is having some symptoms like is well covered with the dopamine for most of the day, but at some moments has some problems, such as I think early in the morning. So the patient, contractions occur in the morning soon after he wakes up and occasionally wake him from sleep. So I thought that the best answer would be switching the immediate acting carbidopa levodopa to a long-acting carbidopa levodopa at night, and that was the answer. I wasn't sure about that one, and I didn't know there was a longer-acting carbidopa levodopa, but just with the context of the question, this made sense, and now you know that that might be an answer. So extrapyramidal symptoms such as dystonia in patients with Parkinson's disease are the result of insufficient dopamine in the central nervous system. Patients on immediate release carbidopa levodopa may need longer acting medication at night to maintain steady levels and avoid unwanted extrapyramidal symptoms. Okay. So now the next question. This other question was one that is just testing your ability to know what to do in a pregnant patient who has hypothyroidism. So if the patient already had hypothyroidism preceding pregnancy, of course you would assume probably this patient, if they're going to their appointments, the TSH is normal, within the normal range, and this patient then gets pregnant. Does the patient need any change in medication? Yes, the answer is yes, because metabolic requirements will increase during pregnancy, so you have to increase the levothyroxine for these patients. How much? I think it was about 25% approximately, and you want to maintain the TSH towards a lower level, or maintain it a little more depressed or reduced, just so this patient is very well covered with the metabolic demands of pregnancy. So, and you will base yourself off the, let's see, I think the TSH in general, that's the best one. So you will measure TSH every 4 weeks and adjust levothyroxine dose to trimester-specific TSH norms. And here you have, you increase levothyroxine 30% at the time of positive pregnancy test. And what else do we have? There's some other physiologic changes with pregnancy. Of course, there's an increase in circulating TBG, which is thyroxine binding globulin. And yeah, that can throw you off sometimes because it can alter the total T3 and T4, and there can be a slight increase in free T3 and T4. So that's why I better go off the TSH during pregnancy. And next question. Okay, this is a question that is testing your ability to know how to reduce the risk of a patient generating DVT if they have a contraindication for anticoagulation. So this patient had a stroke, and a CT scan showed right hemisphere hemorrhagic stroke. So they're telling you they're asking you, how do I prevent deep vein thrombosis? Well, this patient has all the indications to try to prevent thrombosis because the patient is hospitalized, and that's usually enough. And in questions or in real world experience, anyone that is hospitalized, almost irrespectively, you will do DVT prophylaxis. But in the test and guidelines, some patients that are admitted, if they're moving about, they have no limitations, they're getting up, they're going to the bathroom, they're walking, they're ambulatory, but hospitalized, you probably don't need DVT prophylaxis. But in general, due to liability and risks, most of the patients you will see in a hospital will be having one form or another of DVT prophylaxis. But in this specific case, that the patient had a bleed that is not moving one hemibody or half of the body, they definitely need to have some sort of DVT prophylaxis. So you're not going to use anticoagulation here. So choice D is out of the picture. Most of the other choices are out of the picture. So the right answer is intermittent pneumatic compression device. That's the best answer. Okay. So let's see what it says here. Intermittent pneumatic compression started within 72 hours of the acute event is effective in preventing DVT. Pharmacologic DVT prophylaxis may be considered 1 to 4 days following stroke in immobile patients as long as repeat imaging rules out further bleeding. Okay, so even this patient that had a stroke, hemorrhagic stroke, if you repeat the imaging and there's no change, there's no expansion of any bleeding, you can consider the DVT chemical prophylaxis. Okay, next question is asking us what to do with a patient with ankylosing spondylitis that's been having this for several years now, that has already used naproxen, which previously relieved the pain, but recently has only moderate effect. So you have to add something to this. So of course, ankylosing spondylitis, first line will be NSAIDs, and if that doesn't work, then you can consider TNFs or biologics. So if pain relief is not satisfactory, as this patient, adding a tumor necrosis factor inhibitor is the next step. Active infection and latent tuberculosis should be excluded prior to TNF inhibitor use. And that's about it for that question. Now let's go on to the next one. This other question was somewhat tricky because I wasn't exactly certain what was going on. This is a 33-year-old man with asthma, chronic rhinosinusitis, complaining of shortness of breath, had an upper respiratory viral infection, and was given several medications, and took also his fluticasone, salmeterol, and nasal fluticasone, but became more dyspneic over the next 3 hours. He has had sinus surgery twice with removal of nasal polyps 2 years ago. So I did think that there was something interesting with those polyps. That's why I underlined it. And I did sort of think about the Samter's triad, right? Which is, Samter's triad is aspirin exacerbated respiratory disease. So you have chronic rhinosinusitis with nasal polyps, asthma, and of course aspirin or NSAID sensitivity. Let's see. So the question is, which of the following would most likely benefit this patient? And I chose Montelukast because I wasn't sure. I was between Montelukast and referral for anti-IgE therapy. But the main point in this question is that aspirin exacerbated respiratory disease is not immune mediated, so that would rule out IgE therapy. So your answer would probably be Montelukast. Why? Because this respiratory disease, aspirin exacerbated, is associated with increased leukotrienes. And remember that Montelukast is a leukotriene receptor inhibitor. So that was the correct answer. Let's see what else does it say here. Yeah, that's about it. So let's go on to the next question. This other patient is an 80-year-old woman. She has low weight. Her BMI is 18. She had a spiral fracture of the humerus about a year ago, which was interesting to me. So I did think, this patient is old of age. She has a very low weight. She has this fracture of the humerus, not any fracture. It's a spiral fracture. Whenever you see spiral fracture, you think abuse. So I did think, this patient might be abused. But when they ask you what's the most appropriate course of action, I saw this option that said admit to a rehabilitation facility because it made the most sense to me because I thought this patient will be safe there and there will also be work towards her getting better. But that's not the answer. Remember, always you contact adult protective services whenever you suspect there might be any mistreatment, right? And then they will go from there. So that was the main point of this question. And whenever you find the red flags of elder abuse, such as these that we are finding here, you do the adult protective services immediately. So part of me was like, is this enough for us to call elder abuse or adult protective services? And I was on the fence because I also sort of felt bad because this lady lives with her nephew. And what if it wasn't abuse? I was like on the fence. Whenever you find the red flags, just call them. It's better to be safe than sorry. So, next question. Oh, this one, I wasn't sure what it was. This was like an otitis media. We were on the fence, a 76-year-old man with a weird otitis media, which was showing, well, CT scan of the base of the skull reveals areas of bony erosion involving the right auditory canal. Cultures of the ear exudate are obtained. But interestingly, so the ESR was sort of a borderline. Creatinine fine, leukocytes was fine. Patient is afebrile. What's going on, right? There's no like clear reaction here going on. And the patient first experienced mild pain several weeks ago and has also noticed that his pillow is wet in the morning with discharge from the ear. So this is presenting like too slowly. So what they're trying to tell you here is there are some things that might look like otitis media that not necessarily will be that, but could be a cancer. So that's why they wanted you to get a biopsy of the lesion. So it could have been squamous cell cancer. So that was an option, okay? That's a differential from the malignant otitis externa. Okay, so whenever you have malignant otitis externa presents in older patients with diabetes with severe pain, ear discharge, erosion of the surrounding bones, and a very high erythrocyte sedimentation rate. Patients with squamous cell cancer of the external ear generally have milder symptoms, a subacute presentation, and a lower ESR. A tissue biopsy is often required to differentiate between the two conditions. There you have it. Now, next question is, this question is testing your ability to recognize that not only ACE inhibitors can cause this nagging cough in 10%, 5 to 10%. Well, I see that ACE inhibitors, it might be even higher. Not only 5%, it can go up to some studies up to 15%. But in general, think about 5 to 10%, this nagging dry cough after the initiation of ACE inhibitors. And remember that it not necessarily is 5 days after initiation. It can happen years after you started an ACE inhibitor. Well, this patient wasn't on an ACE inhibitor, but had the same weird nagging cough with no findings suspicious for worsening of heart failure. Yes, the patient has heart failure with reduced ejection fraction, but there were no changes. It was actually stable from the cardiac standpoint, and the patient is just having this nagging cough. So what was the reason for this nagging cough? It was sacubitril valsartan, okay? But specifically, the molecule, remember, sacubitril valsartan is Entresto, but the sacubitril is a neprilysin inhibitor, and that indirectly makes the bradykinins be elevated, and that is sort of the same reason you have a cough with ACE inhibitors. So if you have that nagging cough and you're not in an ACE inhibitor, well, guess what? It can be what is replacing the ACE inhibitor, which is the sacubitril portion of the sacubitril valsartan. So there you would have to discontinue the sacubitril, okay? And that's about it for this one. It can happen similar to the percentage of patients that generate a cough with ACE inhibitors, so about 10%. And now let's go on to the next question. This question, I got it incorrect because I wasn't able to differentiate if these findings the patient had were, I thought they were more like mediastinitis over pericarditis. So this is a patient that had a CABG about 4 weeks ago. So the CABG 4 weeks ago, now the patient is febrile. Patient is having chest pain, the patient has to sleep like this. He can't just like lay back. He has to turn to the front. So all those things I read sounded like, oh, this sounds like pericarditis. And I did think, this might be pericarditis after all the CABG procedure and all those things going on. But there was something that I was expecting them to show me some findings on the EKG, but they didn't. It just says EKG shows sinus rhythm with left bundle branch block, which was present on his EKG 3 weeks ago. So I'm guessing now that I look back on it, maybe they were telling me, well, you don't always need to have the specific findings of ST elevation and all these leads for you to suspect pericarditis, because maybe the left bundle branch block will alter your ventricular repolarization, and you won't have the typical findings of ST elevation you expected, but you have to have a high clinical suspicion that this might be going on. So I guess that was why acute pericarditis was the right answer. So let's see. Okay. NSAIDs and colchicine is the treatment for pericarditis. Let's see what it says. Post-cardiac injury syndrome is commonly seen after cardiac surgery and is likely an autoimmune reaction causing inflammation and presenting with the typical symptoms of pericarditis. Treatment includes NSAIDs or steroids. Prophylactic colchicine after cardiac surgery significantly decreases the incidence of post-cardiac injury syndrome. That's a good point right there. Why wasn't it mediastinitis? So it says postoperative mediastinitis typically occurs within the first 2 weeks after surgery and presents with fever, tachycardia, chest pain, and signs of sternal wound infection such as purulent discharge. This patient's normal appearing sternotomy site makes this less likely. Okay. There you have it. Okay. What else? Oh, yeah, see what I was telling you. Most patients after cardiac surgery have some baseline EKG changes, such as left bundle branch block in this patient, making it difficult to interpret the ECG for evidence of pericarditis. That's it. Okay. And let's maybe see two more questions and let you guys go. In this specific question right here, this patient is a 20-year-old male who was complaining of cough, dyspnea on exertion, nighttime awakenings with wheezing, and it started after he was painting a room and using ammonia to clean the windows. So they were asking us here, which of the following would most helpful to establish a diagnosis? So I thought that this patient maybe had some sort of inhalation injury there, and bronchoscopy with alveolar lavage would be the answer. Well, it was not. The answer was methacholine challenge testing. I'm not sure why. So this is a new term for me, or at least I've never diagnosed this in the past. Maybe I've read it a couple times, but it's reactive airway dysfunction syndrome. So it's, in summary, reactive airway dysfunction syndrome is you're exposed to this thing, allergen, in such a high concentration that you generate a response that looks like asthma, basically. And then when you're not exposed to this, I guess you're a little bit better. So let's see what it says. Reactive airway dysfunction syndrome is a non-immune asthma-like illness that occurs after a single high-level exposure to a pulmonary irritant. Pulmonary function testing may show obstruction, and methacholine challenge testing can establish the diagnosis. So here I basically ruled out anything that seemed obstructive because the FEV1 over FVC was 0.82. But it was tricky because it was just showing me the FEV1 over FVC at that moment in time. But if you put this patient through this methacholine challenge test, probably you would find out that this patient had this reactive airway disease. So I guess that might be the thing going on there. What does it say? What else? What other diagnostic criteria do we have for reactive airway dysfunction syndrome? So chronic asthma-like illness after single high-level exposure to pulmonary irritant, onset of symptoms within the first 24 hours, absence of pre-existing lung disorder, airflow obstruction on pulmonary function testing, and positive methacholine challenge test after exposure. What's interesting to me is that this question sounds a little trickier. I'm not sure if it's even well written, because if the patient has obstructive findings, wouldn't you expect this to be abnormal? But the patient is if the patient is having symptoms now, I would expect the FEV1 over FVC to be obstructive pattern, right? Let's see if it says how he's doing now. Yeah, because he is complaining of cough, dyspnea, on exertion, and nighttime awakenings with wheezing. So, yeah, if you're seeing this video, let me know what you think, and what does this mean that the FEV1 over FVC is normal at 0.82? Is it well written, or does it just mean that the patient is sort of not so bad right now, but once they have the wheezing, the obstructive pattern kicks in, at least with this ratio? And yeah, that might be it. So let's go on to the last question. This other patient has been worked up for a whole lot of things. She has a diffuse abdominal pain, headaches, muscle pain, and weakness, constipation, and intermittent tingling sensation in the right arm. This patient has been worked up and everything has been negative. Everything has been normal. She's not depressed, has no anhedonia. So what you're thinking here, probably with all the normal labs and everything, is somatic symptom disorder. So they're asking you, what's the most appropriate next step in management of somatic symptom disorder? So I answered, reassure and recommend no further interventions, because I was like, she's not bad. She doesn't need more imaging. It's going to be more risky than fruitful to continue being exposed to ionizing radiation and potentially harmful procedures. So I thought that was the best answer, but no. What we had to do was recommend cognitive behavioral therapy. We wanted to try to fix the thing. So reassure and recommend no further interventions might sound a little bit like we're cutting the patient off, we're not offering any solution. What is offering a solution here is recommending CBT. So first-line treatment of somatic symptom disorder consists of regular scheduled follow-up visits together with psychotherapy and or antidepressants. Among psychotherapies, cognitive behavioral therapy has the best evidence. So let's see why the option I said was not the right answer. Option C says, although patients with somatic symptom disorder should be reassured that serious medical disease has been ruled out, reassurance alone is rarely sufficient. And let's leave it at that, and I'll see you in the next one.